Good afternoon, everyone. We're going to just give it a couple more minutes to see who all still is to trickle in, and then we'll get started shortly.
Okay. Good morning, afternoon, everyone. Welcome and thank you for joining us today. We're delighted to have you with us for this year's webinar. Just a few areas for housekeeping. Please be sure to mute your line when you're not talking. Please introduce yourself by entering your name and organization in the chat feature. You're also welcome to enter comments or questions using the chat feature. We will be making this recording available in the slides at a later date. My name is Dominique McCall, and I'm a quality improvement reviewer on the quality improvement team. Our colleague Karen McKinney and our team lead Elaine Trepanier were unable to be here today. And I will now take a moment to let the rest of the team introduce themselves.
Hey there, my name is Joe Gamboa, and I'm a clinical service specialist with the QA clinical team.
Good afternoon. My name is Mike Brown. I'm a clinical quality improvement reviewer.
Hello, my name is Jessica Kitchen, and I am a quality improvement reviewer.
We also have Danica Foltz with us today, and she will be presenting a little bit later on peer services.
Thank you, everyone. Now let's review the agenda. In this session, we will have a special presentation, as Joe just mentioned, on peer services and recovery hubs. Then we will move to the quality improvement areas, including intake documentation, risk assessments, treatment planning, discharge planning, consumer rights, staff and client interviews, followed by a Q&A session at the end. Before we proceed, the QI team would like to acknowledge, based on our global observations, we've identified key areas of strength and challenges across various agencies. It's important to recognize that while some agencies excel in certain aspects, others face hurdles. We also recognize that dedication and hard work for every agency and their commitment to the hard work and client care. Your efforts are truly appreciated. To begin, we will have the presentation on peer services and recovery hubs. It over to Danica.
Hi, apologies. My Teams is frozen on my computer, so I will join via my phone. My name is Danica Foltz. I'm the Bureau Chief of Recovery with the Division of Mental Health and Addiction. I'm just going to share a little bit about peers and recovery. So for DMHA, the peer certification is the Certified Peer Support Professional. This is a curriculum that aligns with SAMHSA's national model standards and was created by Indiana subject matter experts. In this curriculum, we ensure to incorporate family peers, professionalize the certification, and remove any barriers for individuals to get certified, such as absorbing all costs for training and examination and having trainings throughout the state of Indiana. In Indiana, a certified peer support professional is an individual who utilizes their lived experience combined with formal training to instill hope, inspire change, and support other individuals through similar experiences using personal connection, person-centered care, and their shared understanding to navigate their life and recovery. To be eligible for the training, you need to be 18 years or older, have a high school diploma or GED, and live or work in the state of Indiana at least 51% of the time. You also must be an individual with firsthand experience and perspectives of mental health, gambling, and/or substance use, service use, or attempts to access service, along with periods of healing or personal recovery. You can also be a family member, which would be a person with firsthand experiences as a family member whose lived experience is advocating for and navigating relevant systems of care on behalf of their loved ones with mental health, gambling, and/or substance use. Everyone in this training must be willing to self-identify as a peer and work to support others with similar experiences. And ultimately, because of their life experiences, they have an expertise that other professionals can't get through a professional training. We are really working to enhance quality and workforce, and through that, we, in 2023, we rolled out the Crisis Peer and Crisis Peer Supervisor certification. The training that I was just mentioning, the Certified Peer Support Professional, was rolled out in 2024, which is a 48-hour in-person training with a proctored exam at Ivy Tech locations throughout the state. To ensure quality and fidelity, we have hired full-time trainers that all have direct lived experience. And later in 2025, we will be rolling out the supervisor certification for peers. The Indiana Recovery Infrastructure incorporates these three things. So one being 10 regional recovery hubs that currently offer peer support services to all communities throughout Indiana. We have 23 recovery community organizations, which are certified to ensure fidelity to serving all individuals with mental health and substance use. And then we have recovery community centers. We have 6 of those, which can be recovery cafes or ultimately just community-based recovery centers that are led by individuals with lived experience. The regional recovery hubs, you can receive individual peer support, group support, you can get family peer support, connections to community, and referrals to other services as necessary. Our hubs complete community outreach. Transportation is available for recovery supports, promote the dimensions of recovery, including home, health, purpose, and community. And then we also have peer support available 24/7 through 211. You might want to connect with a hub or connect others to a hub for peer services for crisis support, mental health, substance use, trauma, or individuals seeking family support. Recovery community organizations are an independent grassroots nonprofit organization providing a variety of activities that are available to all community members in recovery, regardless of their pathway to recovery. And these organizations embody 3 core principles: recovery vision, authenticity of voice, and accountability to the recovery community. Recovery community centers are peer-operated, community-based organizations that provide individual and group peer support. Each recovery community center has unique specialties that make them all different. So at the bottom, you can see some of them might be recovery cafes, faith-based organizations, family peer organizations, or just a community drop-in center where peer support's available. Last but not least, we have clubhouses, which are community-based services dedicated to supporting and empowering people living with mental illness, known as clubhouse members. And the clubhouse model is psychosocial rehabilitation, and each clubhouse offers collaborative restorative environment where clubhouse members can recover by gaining access to opportunities for employment, socialization, education, skill development, housing, and improved wellness. And this is the recovery team's contact information if there are any questions or any assistance that we can provide.
Thank you, Danica. And we will move on to our next section on intake documentation. I'll pass it over to Joe.
Yeah, good afternoon, everyone. I will be taking care of intakes, and I will also be kind of looking at treatment plans, and then I will pass it off. So when we go into review, we work pretty globally. We look at a few different areas. A couple of those areas can be added or changed based off the location setting. We always usually look at intake assessments and intakes and discharges. And so I will be kind of covering the first two areas here. So here you'll see codes that are related to what we expect to see with the intakes and what Indiana Administrative Code expects to see with intakes as well. Code requires the agency to contact the client with 2 weeks of their first contact with the agency, include a psychosocial history, indicate current level of functioning, assess alcohol and or drug use history, and assess for significant functional impairments and things such as like ADLs, psychological functioning, and interpersonal functioning as well. Okay, so like I said, there's a couple of differences depending on the setting type. And so this is for ASR residential, what's different from the ASO and the ASR non-residential. So intakes must include support in the individual in applying for public assistance where appropriate. And then for residential places, TB tests must be completed either 3 months prior to admission or at admission and read within 72 hours. For substance abuse prevention and treatment for our block grant providers, the individual must be screened for co-occurring disorders. This is a quality thing that we look for. So it's not related to a specific code, but we still may kind of mention it as an area of quality improvement. We also expect to see gambling disorders assessed for tobacco use and tobacco use assessed for. And then if there's an issue with gambling, we expect to see the appropriate referrals made if your agency does not provide gambling services. And then if a consumer indicates that they are a tobacco user and they don't deny receiving tobacco cessation or education or the cessation programming, we expect also that to be provided. We often do in our reviews see the education being provided, whether that be a like 1-800 number or like Rethink Tobacco, but we don't always see throughout the treatment it followed up with the programming. So we also hope to see some risk assessments as well. Again, this is not an issue related directly to Indiana Administrative Code, but it is a quality and best practice area that we look at. So assessments for SI can include the following: the Columbus Suicide Severity Rating Scale, an MSE, a PHQ-9, GAT-7, a suicide screening, and a QPR are all things that can be utilized to assess in this area. Assessments for homicidal ideation can include these violent risk assessment tools, triage tool assessing a patient's potential danger from others or to themselves, indicator for violent behavior, quick glimpse of 5 observed behaviors that can indicate dangers to other, and the danger assessment tool, assessing risk to healthcare professionals regarding an individual who's exhibiting signs of potential dangerous behaviors. These are some of the tools that can be used. Also, sometimes in like MSEs and in other assessments, obviously that can be captured in those areas as well. So those are the things that any administrative code task us to look for within the intakes. Now I'm going to switch to kind of the second part of this, and that is treatment plan. And if you think of kind of the treatment process holistically, it kind of makes sense to go in this order because we start as clinicians with the intake, gathering information, identifying problems, identifying, what the consumer would like to work on. We take that information, kind of following this golden thread, and we go into a treatment plan that is based off the kind of initial assessments and the initial kind of narrative and conversations. So any administrative code task us for looking for these specific items within treatment plans. So treatment plans must be individualized. No two consumers are the same, have the same sort of context or same external things happening. So they must be individualized to each individualized person. Completed by the 3rd session. What we mean by that is completed by the 3rd billable session. Timeliness, and this can be dependent again on the setting of when it needs to be done by, when we expect to see reviews and things like that. Attainable goals and how desired areas of change will be worked on. Measurable action to their goal. So these are kind of measurable objectives based on the goal. So if we see a consumer that wants to work on their anxiety, it isn't enough or best practice to simply say to decrease anxiety over the next, 60 or 90 or however many days. We need to see how that's going to be measured and how outcomes are going to be measured and how you will know when the person has quote unquote worked on their anxiety. It may include something like work on 3 coping skills over the next 14 days or something like that, something that is measurable and able to kind of see progress. And then also therapeutic activities and their frequency. So this is, what therapeutic activities are they going to be engaging in while they're in treatment? Are they going to be in therapy? Are they going to be in case management? Are they going to be in skills or even peer recovery? And then how often are those services occurring? That helps the clinician and the client to kind of see kind of what they're going to engage in. And for us on our end, it kind of helps us see, okay, that they're saying there's therapy twice a week. Are we seeing notes that line up with that indication? And is the treatment plan being fulfilled as it's written? So we also expect to see involvement of consumers in the development of the treatment plan. This, as I think we'll get to later, often is indicated by a signature or the goals being written in the client first language, so using kind of their words of what their goal is. Reviewed every 60 days. And any supports that your agency does not provide, that would be indicated based on kind of their intake, we would expect to see kind of external referrals for additional support. And then, so I mentioned earlier, we look for frequency and activities, but we also want to clearly identify who is responsible for those therapeutic activities. This helps us know who's providing the service, but also helps the consumer know who kind of their chart holder is or kind of that point person is. We look for an assessment of adequate support to foster recovery. Is there household one that would support or to foster their recovery, or would it be detrimental to their recovery? And then also the requirements for intensive outpatients as well. The frequency and the time for those services. Okay, so this kind of breaks it down a little bit more. We kind of had saw kind of high level what we look for, and we kind of can break down these codes a little bit of consumer involvement. The consumer shall be involved in the treatment planning process. That can look different for different agencies. And if the consumer decides they don't want to participate, that's okay. We would just expect to see documentation that this consumer denied participating in their treatment plan. And then lastly, for the consumer involvement within the treatment plans, we expect to see their signature. And if they are unable or can't provide their signature to either document that they declined, or if it's like a telehealth service and you don't have the ability to have them e-sign, just indicating that this service was telehealth. Next in-person session signature will be attained. Something like that can indicate to us kind of what's going on with that. Again, timeliness completed by the third session or the third billable service, and then reviewed every 60 days. Each treatment plan shall be reviewed as appropriate with the consumer, but at least every 60 calendar days. So that is saying that, you know, there might be a significant life event that a consumer may have, and maybe their goals and their objectives and their problems identified completely shift. And so we need to kind of revise the treatment. But it should be at least done every 60 calendar days. As we know, people in treatment and recovery, their lives and their progress is very fluid. Sometimes it's, steps forward or steps back. And so we want to make sure that we're kind of capturing that progress or kind of barriers to progress within the treatment plan. And then, of course, I mentioned kind of at a higher level earlier that each consumer shall have an individualized treatment plan. No two consumers have the same issues or have the same or are within the same context. And so we expect that each treatment plan be tailored to each individual and their needs. And then each consumer shall have the opportunity to participate in developing their plan. Ultimately, it's their plan, their treatment, and they should be the ones kind of driving. And again, as I mentioned earlier, if the consumer denies to participate in the treatment plan, we just expect to see some sort of note indicating that they did not want to participate in developing their treatment plan. Yeah, I think another part of treatment plans is the goal writing. This is kind of number 5 here is referring to when treatment plans are reviewed. There should be a kind of narrative about the progress or the attainment of the treatment goals within that review. So kind of, a quick little excerpt of, how how the consumer is doing on each their goals. Again, goals change, you obtain goals, new goals come up. So we want to make sure that the treatment plan is congruent with what the consumer is needed. Again, specific goals should be written in terms of measurable criteria for each proposed outcome, for each identified problem. So it's not best practice or enough to just say, I want to work on my anxiety, or I want to work on my depression. How are we going to work on that, and how are we going to be able to measure? Are we going to, have the goal of learning 2 coping skills over the next week and then kind of going from there? So we need to be able to see some measurability and those goals. As I've kind of alluded to earlier, when I first kind of started the treatment plan, if we kind of think of the progression of treatment, we kind of start with the intake and we move into treatment planning. But the treatment planning does not exist in a vacuum. It is very much done in a collaboration with any intake assessments, any ANZAs, anything like that should be considered with the treatment plan. We've gone over a lot of these things. These are maybe some of the findings that we find a lot. We don't often see, I don't think I mentioned anything about financial counseling being indicated in the treatment plan, but that's something that we often don't see. And then clearly identify the responsible clinician. Sometimes we'll see that there's therapy or anything or peer services and stuff like that, but we don't know who the responsible clinician is. With that, again, if there's any questions about intake or treatment plan, we'll have time at the end to answer any of those questions. You can put them in the chat or wait till we're kind of wrapped up with this. But for now, I will toss it over to Mike to talk about discharges.
Good afternoon. Just going to speak briefly about this, and then we'll be transitioning to another topic. But this does in many ways kind of continue that theme about the golden thread. As with the intake and as with the treatment plan, we still want to see that consumer involvement. And ideally, as the person has moved through services and they're about to reach discharge, all that planning for the next step is occurring. And it's all being hopefully reviewed with the consumer as they prepare for that. And so part of that is, evaluating each of the outcomes for the goals that they had in their treatment plan. Sometimes we find a little bit of a mix on that. Sometimes it'll be that some of them are covered, or some of them are kind of described in really global terms for the entire thing. And it looks a bit more like a final evaluation than like an outcome for each of the goals. Emphasize that there's a distinction there, and that if you can have information about each goal and kind of what ended up happening with that, that's much more in alignment with what the code is expecting. And with the final evaluation, that has some wiggle room as to far as what kind of content can be there that may kind of describe what their attitude was about their experience, what they may have gained from it. Maybe something about the prognosis. It may be just kind of capturing some of that part of it there, overall state after having gone through the treatment. And then recommendations, we like to see recommendations. And sometimes the question kind of comes up, what if they leave AMA, or something like that, or they've just kind of completely dropped out. And usually what we kind of suggest for that is, if that happens, it's obviously difficult to create recommendations for that situation. But even if it's as simple as something like, patient can return to services, or it's recommended that they continue to seek services for the needs because they've yet been resolved, or something to that effect. If that can be documented, then I think that's as good as you can do, really, in being in compliance with the recommendations piece. And then, of course, we look to see if the discharges are completed within 30 days. And again, ideally with the consumer, but if you can't do that, we usually encourage providers to put notes in the chart or the file that kind of explain that maybe it was mailed to their last known address, and that there may have been some attempts at following up with them regarding those things. I think now it goes to Dominique.
Thank you. These are some of the significant areas where we had findings with consumer rights documentation. The right to refuse treatment was frequently absent from client rights notifications. But during a follow-up we did, we found several agencies that noted that they had a misunderstanding with the interpretation or application of various areas of the Indiana Administrative Code. Adherence to 42 CFR Part 2 was not consistently included. So all confidentiality notifications should include this language. So this will ensure that patient rights are adequately protected and the organization remains in compliance with applicable legal standards. And moving on to information disclosure, documentation supporting the release of information or ROIs for external collaborators were often either not created when applicable, missing a client's signature, or had incomplete fields such as who the RI was being sent to or what the RI was allowing for the information to be transferred, which can lead to potential breaches of confidentiality. Consent for treatment forms for ongoing treatment were often outdated or absent from client records, and this poses a significant risk, including potential legal implications and ethical concerns. And I will refer back for medication policies.
Okay, with medication policy, one of the things that we look at when we visit some of the ASR settings, residential, is the employee files. Within the 7.5 code there, it requires that staff who are providing services and direct care with the clients or residents receives training about basically the kinds of medications that they might use for their respective diagnoses, what the purposes and the objectives or hope for the medication, what it will do for them, and then understanding something about the potential side effects and things like that that might occur. Also connected to that, just if they may not be actually taking the medication. Looking for signs of that is important, or that it may be being misused in some way, or it's just not working for them, and maybe some sort of an adjustment to their medication needs to be made. But it's important for staff to kind of be able to recognize some of these things so that ideally the resident is getting the right kind of care and is reducing risk too. Next slide, please. The next part is with residential settings. Also, we do tours and we do interviews of staff and residents, and there were some themes that began to kind of emerge from talking with and seeing some of the different locations. And so kind of the top 5 items that I'll go into a little bit more detail about here in a minute were restrictive money practices, incident reporting, and procedures regarding fire drills and safety and emergencies, medication practices, and then cameras in private spaces. Next, please. With the restrictive money practices, we found sometimes that with the best of intentions, staff were sometimes holding on to the client's money and valuable possessions and things like that. In part, I think, to be protective, in some instances, concerned, and maybe rightfully so, that the president may not be in a frame of mind to handle those things appropriately. But the code doesn't really differentiate that, and so they basically expect that people will have access to their items and be allowed to have money on them. So some of the workarounds have included things like being able to provide the security and yet meet the code by having things like lockers where the resident would be the only one to have the key, and they can put their items in there, have the key with them, and then they can access those things as they see fit, which kind of bridges those 2 areas that can feel at odds in a way. Another thing too is if those aren't really feasible, it's important maybe to obtain their approval for doing that. Once you've had them sign off on something that says that they're willing to have these items held for them, as it were, then that would probably satisfy that requirement. Next slide, please. Incident reporting, we sometimes find that sometimes things aren't reported that probably could have been. Sometimes there are also the occasional late submissions. So we have just encouraged people to look at the 7.5. It has some guidance in there about what to report and when to report it. And just also sometimes in the interviews it became evident that um, not everyone, and this was true for staff and residents, not everyone was entirely sure what certain procedures were as far as fire drills and where to go and that sort of thing. Also not entirely clear on when the drills were practiced or how those were managed. So also just encouraging folks to kind of re-examine those things and make sure that there's greater awareness on some of those points so that people are feeling comfortable and better able to respond to needs as they arise. Next slide, please. And kind of following up on that, fire drills are required in 7.5 to occur monthly, and at least quarterly there should be one that's on a different shift, like at night. And there should also be a tornado drill done every spring, just to help people be prepared for that, because we know it can obviously be a turbulent time of year. Next slide, please. And then with the cameras, what we found is, again, with the best of intentions, typically in terms of therapeutic observation being the goal, there were some rare instances where cameras were located in the residents' bedrooms, and that led to a discussion with the legal department, because technically, as you can see in IC35, that can become an instance of voyeurism if people haven't been properly or duly notified that this might be occurring, even if it's for therapeutic purposes. So what we've generally concluded was that it was appropriate to remove the cameras from those spaces where people might end up in a state of disrobing or nudity for whatever reason, like restrooms, bathrooms, showers, maybe even their bedroom if they're doing that in there, or just making sure a lot of places have therapeutic camera surveillance sorts of policies and things, but just making sure that it includes that detail that they may be being observed on footage in that state, making sure they know that, and obtaining their signature or consent on that would be important. Next slide, please. Some other things that occasionally showed up in policies, and this sometimes necessitated the addition of some of these points. Verifying that the individual has been informed that they have the right to manage their financial affairs or to seek assistance with that, unless they're under a representative payee or a court-appointed guardian for financial matters, is an important piece that's occasionally not included in the rights, and it needs to be. Also, similarly, being able to access legal and advocacy services at their own expense is something that's also a right. And they also, if there is some kind of payee-ship or financial involvement, having the records and maintaining those carefully and making those available when appropriate to be reviewed is another right. And then this is a not necessarily a right, but it's a policy issue that we've sometimes seen, There's sometimes medication policies that are directed as to far as storage, administration, records keeping, those sorts of things. The law technically requires that those be developed in consultation with experts in the field, like nurses, pharmacists, physicians, and sometimes that's lacking. So what we often encourage, and when we see it in compliance, is simply there may be a blurb or just a statement in the policy that indicate that it was in fact developed with these people, or sometimes it will appear somewhere in the document just that this was developed by, and then it has the name of the person and their credentials, and that can satisfy that requirement as well.
Thank you, Mike. So in closing, from this year's review, our team identified overall inconsistencies in required documentation, which often hinder reviewers' ability to connect each step of the treatment pathway, often referred to as the golden thread, which Joe described previously. We encourage each agency to revisit these policies and codes to which you have attested in order to confirm that your accurate application within your procedures. The next slide shows how these findings have led to a rise in extensive corrective action plans, an increase in technical assistance trainings, and several agencies being placed on conditional status. As you know, these conditions adversely affect service delivery and potentially harm the vulnerable populations that you serve. Our overall findings highlight the need for improved documentation practices and enhancing training programs or administrative requirements across several agencies. The next slide shows where you can find further details on these topics through these resources provided. And you can you will be able to find the recording of this webinar and the slides available on our website at a later date. And the next slide is just a acknowledgement that while complex challenges have been discussed today, we believe it's also important to celebrate the unique strengths that each agency brings to the collective efforts. And we believe that the hard work and dedication you have demonstrated in your daily tasks are sincerely valued and make a tangible difference. If we have any questions, you can take yourself off mute or you can make a note in the chat.
So just Brooklyn, to kind of anecdotally answer your questions. Sometimes we would expect to see an incident report if particularly like in a residential setting, if there was a consumer that hit another consumer or another staff member. That's kind of the one that kind of comes to the top of my head when thinking about incident reports.
And so I guess the one that comes up the most is incidents requiring local police response. Because there are times that 911 is called, but it's not necessarily a big ordeal. It was just called. And so we get the conversations a lot. And then also serious injury requiring professional medical attention. We also have residents, clients that go to the hospital a lot, but not due to injury. like maybe their blood pressure dropped really low and they needed to go to the emergency room. So they required medical attention, but they weren't injured. And so I guess I'm just curious if there's more like specific information on these that everybody can have on hand that kind of further goes into them.
Yeah, let me see if I can find that code item for you real quick.
Okay.
It looks like there's a couple questions about treatment plans being developed and within the first 30 days, and then updates for client receiving service of CMHC's 90 days. I don't know, Dominique, Mike, I don't know if you have anything to add to that while I look up this other item.
I was actually looking up answers for another question. There was a question regarding subacute residential facilities do not need to meet the 3-session rule in 4.4. When I look in 4.4, I do see the requirement for having the treatment plan completed by the 3rd session, so it does seem that that would still apply.
Jamie, I think that's a great question. I'm writing it down to get further clarification, but I do kind of the top of my head do sense that sometimes like 4.4 maybe trumps 7.5. But let me get further clarification.
I'm looking up the question about CMHC. We didn't review for that treatment plan updates. Receiving services from CMHCs are still 90 days. We didn't review for that this year, but I'm gonna see what I can find.
Regarding incident reported, I'm sharing the code here in the chat that you can look up for further clarification.
In regards to the CMHCs and treatment planning, 440 IAC 9 related to CMHC certification states 90 days, yes. And agencies must follow the policy associated with their certification. So if something we said falls under a different policy or code that's outside of substance abuse that we're talking about today, then you need to reference your specific area of treatment and refer to those codes there. And 7.5 states 90 days for residential settings only. Outpatient only ASOs or ASRs must be 60 days. We're actively working on getting policy aligned in that area.
To give a better answer than the sharing the code and the chat, here are some things that would indicate the incidents to be reported. So the agency should report any of the following incidents to the division within 1 working day. Any fire requiring a local fire department response, any emergency rendering the resident temporarily or permanently uninhabitable, any serious injury of a resident or household member requiring professional medical attention, a suicide attempt by a resident or household member, any incident involving the resident or a household member requiring a local police response, suspected or alleged exploitation, neglect, or abuse of a resident or a household member, the death of a resident or household member. And with those reports, the division can determine if the reported allegations warrant an investigation. If it does, the division may conduct an investigation, and the agency is expected to fully comply and cooperate with any investigation by the division or its agents.
Does that help you out on that question?
I believe that was Brooklyn that asked that.
Yeah, I just keep getting questions more so directly related to the injury one. And I was just curious if there was like a list of serious injuries that would fall under this.
It
I
seems like
think
it just need to report it all and then let us
so.
weed out those things.
Related to any serious injury, code states if it requires any serious injury of a resident or household member requiring professional medical attention. So any injury that would require a professional medical attention would be reportable.
Okay, thank you.
Well, that is all we have for today. We thank you so much for your attention.
Thank you.
Thank you.
Thank you.